Dr. Wyndham Wilson, MD and Senior Investigator at the National Institute of Health in Bethesda, will talk to us about the current options in the treatment of large cell lymphoma. Dr. Wilson, can you tell us which treatment strategies work for large cell lymphoma?
Well, I think that's a very complicated question. The last 30 years has really looked at large cells as a single tumor type. And we're now understanding using genetic tools that large cells are actually multiple different tumor types. And it's really been only in the last 10 years that we've been applying this to clinical trials and understanding that a therapy that works well in one type may not be the optimal therapy for another type. I think it's fair to say that we're still in a point where R-CHOP is considered to be the standard of care across most large cell lymphomas. But I think there's enough data coming out in certain subtypes that is beginning to show that other regimens may be preferable. Recently, in the last 6 months, we actually published a manuscript of dose-adjusted EPOCH-R in primary mediastinal large cell lymphoma, one of the subtypes, showing the dose-adjusted EPOCH-R had a cure rate of over 90% without radiotherapy. And there was another series done at Stanford which showed the same thing, and a small series was recently reported in the New England Journal in a letter showing a similar outcome using dose-adjusted EPOCH-R. So I think it's fair to say for at least that subtype that R-CHOP wouldn't be considered to be the standard, and that more aggressive regimens would be a better option. And I think an alternative option to dose-adjusted EPOCH-R in that group would be the French regimen using R-ACV-BP, which is also an aggressive regimen. I think that as we turn to tumors such as the MYC-positive large cells, there's been quite a bit of data recently showing that translocated MYC, as well as overexpression of MYC in combination with overexpression of BCL2, are adverse prognostic factors for R-CHOP therapy. And we actually have an abstract here at the meeting, which will be shown by my colleague, Dr. Dunleavy, showing that with dose-adjusted EPOCH-R, we don't see any adverse impact of either BCL2 or MYC on the outcome of dose-adjusted EPOCH-R-based patients. So one could argue that you might want to use a regimen like dose-adjusted EPOCH within that group as well. I think which is a little more unclear is what would be the standard of care within the more common subtypes of large cell, that is the germinal center type as well as the activated B cell type. And again, we do have some very interesting data, and at least for the germinal center type, the dose-adjusted EPOCH-R may be better than R-CHOP. Having said that, I think for us to really be certain of that, we'll need to wait for a randomized study, which we conducted in the U.S., which is now finished accrual. And that's a randomized study of dose-adjusted EPOCH-R versus R-CHOP in untreated large cell. And a critical part of that study is that we collected tissue, and the outcome is going to be analyzed by the subtypes, that is to say, by activated B cell and the germinal center type. And so I think we will be able to get the first handle in a prospective manner on whether or not another alternative to R-CHOP may be better therapy for some of the more common subtypes of large cell.
Thank you very much.